I am back with my friends, which I am missing you very much. Oh my God, after more than 168 training programs, operating more than 3,000 challenging cases, hands-on for more than 5,000 gynecologists, and I was a regular guest in the AISOG for 8 years. So if there is 10,000 doctors in AISOG, so I'm very proud and privileged to shake hand to 80,000 gynecologists in India. Does this looks nice?
It does.
And I'm very happy that Dr. Shankari is with us. Please give my love to Selva Mani and Divya and everybody, to Joseph Korea, Dr. Geeta. Maybe some of the audience are in this picture.
Well, thank you so much. Thank you.
Okay, so Reddy asked me to talk about hysteroscopy in the field of infertility. We all know that endoscopy is very attractive. And long time ago, it was laparoscopy is the hot spot. Everybody was interested to learn and to do laparoscopy, assuming this will help in infertile subjects and might improve the results of pregnancy rate. But we have to agree all together, but by time and by the improvement of assisted reproduction technology, the need for laparoscopy has dramatically fallen down. No more now salpingolysis, no more fimbrioplasty, no more tubal. It's now dying. So with the decline of the place of laparoscopy, there was a very obvious, tremendous awareness about the role of hysteroscopy. So before I come to today is my operative day. I wake up 5 a.m. in the morning. I want my audience to learn the lifestyle. You have to learn from me the lifestyle more than to learn hysteroscopy. I started 5 a.m. and I started to search the literature, trying to find what is new. I want to find some data to impress you about the value of hysteroscopy. So I found this systematic review and meta-analysis by my friend Attilio Despizio Sardo from Italy. And unfortunately, it was very, very frustrating to me because the conclusion of this systematic review, they found there is no evidence about the role of hysteroscopy. Oh my God, that's killing for me. And it's unclear whether hysteroscopy before IVF could improve the live birth rate. More than that, there is a moderate quality evidence that hysteroscopy could increase the pregnancy rate, and they found low quality evidence that hysteroscopy might increase pregnancy rate even if you remove the submucous fibroid. So after reading this, I want to commit suicide. I tried to find another reference. So I found this recent one, 2019, from the Cochrane Library. Okay, already they did, question is screening hysteroscopy in subfertile women and those undergoing assisted reproduction. The results, the conclusion, there is no high quality evidence to support the routine use of hysteroscopy as a screening tool. So people who hate hysteroscopy are very happy now. I could see the smile on some faces, and I could some others are crying with the tears that Osama is dying. And I am really very frustrated. Should I stop presentation now and go home? Or no, I am fully determined. Are you hear me? I am fully confident that all these reviews are wrong. And by the way, Dr. Shankari, it's a very, very difficult task that Osama is standing alone against this tsunami of publication. Okay, please share with me, and at the end you decide. Assisted reproduction came with a marvelous improvement of the pregnancy rate. Definitely the protocols of induction of ovulation and intracytoplasmic sperm injection, you have 100% success rate in ovulation. Nobody can deny this. And almost all ova came fertilized. But how can you explain there is only 40% pregnancy rate? It's the cavity. To those who wants to deny it, I insist, most of the factors related to the cavity. But look at this man. Everybody know this man? Okay. Many people claim, Osama, we do a lot of hysteroscopies and there are no relevant findings. The cavity is normal. So hysteroscopy didn't add something more. Do you hear me, my friends? I want a feedback. Do you hear me or no?
Yes.
Hello?
Yes.
You hear me? Okay.
Yes.
So,
yes.
I want to answer those people who claim that despite we do a lot of hysteroscopies in infertility, but there is no findings inside. But, listen to my but. Are you sure that when you are inside the cavity, you are able to put a diagnosis? I am so impolite when I say this. How many of those who are doing hysteroscopy can diagnose chronic endometritis? How many? How many people can see these micro polyps and osteal polyp and the endometrial congestion, which diagnose chronic endometritis, which is present in 40% of failed IVF? So you go to the cavity, it's a normal cavity. No, it's not a normal cavity. How many of real competent hysteroscopists who can see this little bulge of a submucous fibroid? How many can see the signs of adenomyosis? So I'm sorry to say, those who say that the cavity is normal, no, it's not normal. It is you who cannot see the problem. Look at that, what the expert find. When I mean expert, those who are competent, hysteroscopy is not as easy as everybody thinks. For any gynecologist, listen to what I say, this is very important. For any gynecologist, if he look by laparoscopy, it doesn't require any skills to know that if this ovary is normal or not. Any regular doctor will know that. But how many real hysteroscopists or gynecologists can see inside the cavity of the uterus and get the diagnosis? I'm sorry to say, it needs a lot of experience. Look what the experts say. This study about more than 500 consecutive cases of infertility, and this was done in a competent hysteroscopy center in France. The rate of abnormal findings range from 30% at the age of 30 years up to 60% when the patient is older. So the conclusion came that office hysteroscopy should be part and first line of exam. Let me say something more offensive. If this study was done in some other place by other doctors, they will come by the conclusion there is no value for hysteroscopy because the cavity is normal. I hope my message is clear. It depends who is looking inside. Oliveira's study in fertility and sterility was a groundbreaking study, but nobody is listening to him. Still, they come with the meta-analysis and blah, 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 that hysteroscopy doesn't show something. Look at what the experts say. The study included more than 500 cases of failed IVF. So this patient attempted assisted reproduction and failed. When hysteroscopy done, there was 45% abnormal uterine cavity findings, which I am confident it was missed by other people. And the other people came with the conclusion that hysteroscopy doesn't add more. And this study was extended further by hysteroscopic correction of the cavity problem and repeat IVF, the success rate jumped to 50% instead of 20%. Does hysteroscopy help to prevent failure of IVF? Yes. Look at the literature. Look what the people found. These multi-center studies by Demirel in Turkey and Gurgen and Monet and Miki and Dolly from USA, many doctors, they compare the hysterography findings versus what the hysteroscopy found. Abnormal findings by hysteroscopy was found in up to 56% of cases claimed of normal cavity. Let me draw your attention to an issue that very, very few people talk about it. Hysteroscopy means uterine cavity, but nobody have talked about the bottleneck, the cervix. Yes, hysteroscopy is not only for the cavity of the uterus. This was my message, and every colleague in India now is aware about this. I'm very proud of all of them. Hysteroscopy can show you more abnormalities in the cervix than can you think. And this article showed what are the anatomical causes of a difficult embryo transfer. How many times you say failed embryo transfer? Yes, because of the tortuosity of the cervical canal, the angulation of the cervical canal, the stenosis of the internal os. All these things might lead to failure of embryo transfer and low live birth rate. Hysteroscopy can do a lot in the bottleneck. Maybe this was not in your expectations that I'm going to talk about the cervix. Yes, introduction of the hysteroscope through the cervical canal to the uterine cavity could facilitate future embryo transfer and definitely increase the pregnancy rate. And you have a lot of references. Hysteroscopy allows an opportunity to know the direction of the cervical canal. I know that I'm not an IVF man, but I know that you depend on ultrasound for embryo transfer. Ultrasound is black and white picture, is a shadow. But hysteroscopy is the real, you see the tunnel. When you see the tunnel by your eyes, you know how to introduce your cannula. And lastly, the reference from Japan that performing office hysteroscopy before ovarian stimulation could possibly increase the ease of embryo transfer. Every day I receive messages. This from Dr. Kusum from Haldwani. If you know where is Haldwani, she said, okay, good news for you, Osama, that one of the difficult cases of cervical stenosis, and she had a failed IVF, hysteroscopically done by you and conceived. So many cases like this. So cervical canal is an issue to be considered for the value of hysteroscopy. Okay, let's go into the cavity. What are the possible findings which might affect fertility or failure of assisted reproduction? Polyps, uterine fibroids, congenital anomalies, or adhesions. When we look at the polyp, okay, please don't ask me the question to remove or not to remove. This is not for me to decide. I'm the one to teach you and tell you how to remove, okay? To remove or not to remove, we go to the literature. Okay. That's a systematic review by the Cochrane about the management of endometrial polyp in subfertile women. That's a systematic review published 10 years ago. And I know that you value the power of the study if it's randomized or not randomized. This is a randomized controlled trial which reported a significantly higher pregnancy rate when you remove the polyp before IUI. So what I want to tell you is very unfair that you have $3,000 US embryos and you put them into a cavity with a polyp. This is very unfair. So the question is not to remove or not to remove. The question should be how to remove. If I ask you to raise your hand now, how many of doctors remove the polyp by hysteroscopy? Maybe today, yes, there is a great awareness, but in the past, it was by DNC. DNC will miss the polyp in 70% of cases. So please, no more deliberate crime. That's the DNC, or I call it you don't see. So I'm very proud that each and every young, simple, humble doctor in a little village in India, they became very competent to push the scope through the cervix, even without anesthesia, and to see the base of the polyp and to cut from the pedicle, like this. See and treat. That's a simple polyp in a case of also failed IVF. No need for dilation. No need for anesthesia. And use the scissors, please, please. Don't use electrocutter here. Just the scissors. And it's finished. If you are counting the clock, it's 4 seconds. Another polyp. Under vision, you can see the pedicle. You will not miss it. When you do blind curettage, you will hit the polyp. You take part of it, but the pedicle is still attached. There is no comparison between blind procedure and under vision. Many of my audience now definitely work together. Dr. Shankari invited me to Murti Hospital more than 12 times, and we did so many cases like this. If the polyp is large, then the scissor might cut the pedicle, but you cannot take it out. So only for large polyps, you do the resectoscope. So again, to remove or not to remove is not the question, but my topic today is how to remove it. My job in the world is to show people how to do things. The value of doing it for you to assess. How to do resection using a monopolar or a bipolar. Okay. Congenital uterine anomalies is a major factor for failure of assisted reproduction. If you look at the general population, almost 6% they have a uterine anomalies. If we focus to zoom on infertile population, the incidence is even doubled up to 14%. If you focus, zoom in more in patients with recurrent pregnancy loss, 1/4, 24% of them, they have congenital anomalies. This is the most recent classification. I know this picture became very famous. Everybody know it. It's not only for uterine anomalies, it's for the female genital tract, uterus, cervix, and vagina. Regarding the uterus, when we say type 0, which means normal. So U0, normal uterus, C0 means normal cervix, V0 means normal vagina. So U1 is the dysmorphic uterus, which is the T-shape or the hypoplastic, and then we come the most famous and the most popular, which is the U2, the septate uterus. Everybody looking to this hysterography might get confused. Osama, what's the diagnosis? It's a septum or a bicornuate. I think now everybody attempted my training courses. They know how to put the concrete proof diagnosis that this is a typical uterine septum. Look at the angle between the corneas, okay? So when you have this Bugs Bunny with an acute angle between both cornea, this is 100% septum. But if you have this wide, this is the dog ears, okay? Wide angle, you cannot tell. It could be a bicornuate. It could be still a broad septum. So how to differentiate by 3D ultrasound? So please, everybody, appreciate this image. I want everybody to put it in his mind. This is the endometrial line, the other endometrial line, and this triangular tissue in between is the uterine septum. If you inject fluid during sonography, it's a sonohysterography and a beautiful view of a uterine septum. So can I make a quiz? Okay, Dr. Reddy, tell me what's your diagnosis. This is endometrial cavity. This is the other endometrial cavity. And don't be afraid to make a mistake. And this is the space in between. The space is dark black. There is no tissue. So what's your diagnosis, Dr. Reddy?
Bicornuate uterus.
Excellent. Okay. Big applause to Dr. Reddy. Tonight, you have a tandoori chicken bonus from me. That's a bicornuate uterus. And this is a beautiful 3D picture showing a different types of a septum. That's a short septum because it's midway between the internal os and the fundus. And this is a long septum reaching internal os. Actually, during the presentation, the last presentation, I was actually finishing a case of a complete septum like this one, exactly like this one. So my son would say, Dad, you're gonna show off in front of the people and say, I finished the septum in 5 minutes. If any doctors can do it in 10 minutes, if you know the rules. And this is the complete septum reaching the cervix. So I gotta upload the case I done half an hour ago. And this is different views by 3D. Okay, so the technique I've just done 20 minutes ago is using the resectoscope. My message to everybody that metroplasty is a plastic operation. It's a plastic, it's not just cut and forget. And let me explain why many studies trying to prove that septum surgery is not needed. And they claim that when they corrected the septum, the results of pregnancy was not much different than no correction. I have to be rude and say, because you didn't do it right. All right. So the technique, I don't want to say much, but I'll go quickly. The purpose of my lecture is to show the value of hysteroscopy, but for the technique, you have to come to my training program. So just attain a proper intra. This case was done in the center of Shruti Hospital with Dr. Shankri and Divya. Okay, so attain a proper pressure inside the cavity and don't ask me how much pressure. There is no number to tell. Every uterus is different, but you have to stretch the septum and have the Collins knife exactly in the middle with the tubal ostium as your landmark and move from one side to other side, putting the tubal ostium as a reference point until you have a final. I can stop at this slide and speak for about half an hour, but I don't want to waste time about the technique. Okay, about the technique, you have to come to another webinar. But today, I want to tell you this is the view that I had in the case finished only half an hour ago. So let us see how to do the procedure. That's the apex of the septum. One tubal ostium. Keep exactly in the middle. There is a lot to say about the technique. It's not just a cut. If you look at my colon knife, sometimes I go a little bit high up. Sometimes exactly in the middle. It's very, very technically delicate. These are the fibers of the septum. Septum is muscle fibers. And when I reach near the fundus, the technical delicacy becomes more needed. You see, just touch and go back. Just go back. Zoom in, zoom out. Have a panoramic view. Look at the ostium. Look at the other ostium. And see how much more you have to cut. It is a plastic procedure. You are like a tailor making a dress. Leave it to watch how I play with the zoom. I am also very proud that each and every gynecologist in India are doing it better than me now. You have plenty of cases. You learn it well and you do it excellent. And that's the final view. So the usual questions. So after septum release, it is not removal, it is release. Should we put a catheter? No. No Foley's balloon, no IUCD, no eastern progesterone. Look at this. This is a $1,000 picture. It shows you the process of healing of the septum. This is that white triangular space. This is the normal endometrium, and I will show you only 1 month. After 1 month, the healing started. This is only 1 month after surgery. Look at the tubal ostium and the healing. Let's go for another look after 3 cycles. After 3 cycles, complete normal cavity. No evidence of white tissues. Everything is epithelialized. And that's before and that's after. I can hear your enthusiasm. I feel everybody's happy now. Okay, so some feedback from Dr. Vishwas from Mumbai, from Navi Mumbai. Osama, since I started following your technique of metroplasty, many patients became pregnant without using ART. And this lovely doctor from Guwahati, I have been doing septum resection canalization only by learning from your videos. So the videos are available on YouTube, and you can see there is 2 million viewers, and 1 million, they say, yes, we like it. But unfortunately, Dr. Nashar is hearing me now. He's my colleague in the university, and we always debate together. Dr. Nashar is a very scientific man. So, Osama, what is your evidence about cutting the septum? Still, some people say, don't cut. Okay, don't cut the septum. No need to cut the septum. And those who are very angry against metroplasty, they want to prove that hysteroscopic intervention does not add any value. So some doctors from the Netherlands, from Europe, designed the TRUST study. What is the TRUST? It is the randomized uterine septum transection trial. They were trying to randomize cases between correct the septum or don't correct the septum and see the pregnancy rate. Should we trust the TRUST? Unfortunately, I can stop and speak 1 hour to show that the TRUST study is absolute failure. Absolute failure. The participant in the study is almost more than 15 doctors, okay? I have to be honest. I know them by name. They are excellent scientists, top people, but some of them are excellent IVF people, and very few are real hysteroscopic surgeons. So if you look at the results from the centers, those who are doing good hysteroscopy, I know them by name, okay? The results of pregnancy rate is excellent after the metroplasty. And other names, they are the top famous infertility IVF people, but the results are poor. I'm sorry to say, you know how to do EXI, but you don't know how to remove the septum. You think just to go and cut. And on a confidential communication with some of the participants of this study, they told me that many of the cases done in the study, they had to repeat it again because the septum was still there, right? So the trust after 8 years are not published up till now. Okay. I see some people are laughing, okay? Right. Let me move to the T-shaped uterus, right? T-shaped uterus in the classification of anomalies is the U1. But actually, there are more classification now for the T-shape by my friend Luis Alonso, published in Fertility and Sterility. They added another 2 varieties. This is not a T-shape, this is a Y-shape. So in the Y-shaped uterus, there is also a fundal cupping and narrowing of the lateral wall, okay? It's absolutely a 3D ultrasound diagnosis. Some people say, okay, Osam, what about this picture? Okay, from this picture, you will say it's excellent view for a T-shape, but believe me, for this patient, if you repeat the hysterography next cycle, you might find a normal shape cavity. Sometimes myometrial, this is a very important message that everybody should put it in his mind today. Myometrial contractility during the hysterography can change the shape of the uterus and give you wrong impressions. So don't depend on hysterography alone. You have to do 3D ultrasound and to measure the lateral walls, okay? At hysteroscopy, if you are expert, you can diagnose a T-shaped uterus. This is a view of a normal cavity. So, Dr. Shankari, we work together. You know that when we are standing exactly at the level of internal os, you can see both osteo well. But in T-shape, you cannot see both osteo. So, correction is by hysteroscopy. I prefer doing with the scissors. Some people doing by the resectoscope. Look at the lateral wall. Actually, this is a Y-shaped uterus. I did correction of the fundus first. This is the fundal correction, and this is the lateral wall correction. Again, T-shaped uterus needs a 1-hour lecture alone, but this is before, this is after, and the 3D is very satisfying. Does correction of a T-shaped uterus helps? Yes. People who depends on the literature, and we have to respect the literature. This paper for 24 years experience for correction of T-shaped uterus. I think these people were working on T-shaped uterus when I was still in the kindergarten, okay? So I'm not an old man. So the live birth rate increased statistically following metroplasty, raised from 2.5% to 60%. Impressive. In parallel, the miscarriage rate was dramatically reduced from 78% to 22%. So should we correct the T-shape or not? Don't say yes. The answer is provided you are competent enough to correct the cavity, not to mutilate the cavity. T-shaped surgery is very technically difficult. Hysteroscopy is deceiving. Like many people said, Osama, when people look at your videos, they think it's easy. Everybody go inside the cavity and they destroy the cavity. If you destroy the endometrium, this patient is finished. So T-shaped surgery is valuable. Yes, another literature, this study published only 2 months ago, 2020. And Dr. Pabucu is my friend. He trained very well with me. He's from Turkey. And Dr. Victor Gomel is the icon of infertility and the conclusion that metroplasty in T-shape improved the pregnancy. PRP became a fashion. Okay. This study came about the value of installation or perfusion of PRP inside the uterine cavity. It was a pilot study, and 18 patients out of 21, they got pregnant. So the technique depends on installation. You just inject PRP by an IOI needle. So I thought that if people are doing PRP for the face, for rejuvenation of the skin, they inject it under the skin. So this is actually, I call it superb because I put S, which means my name, because people copy my work and they don't acknowledge me. Shauki in subendometrial PRP. How to do it? Like this. Look at this. Now, in the cycle before embryo transfer, I used the open pickup needle. This is actually the thesis of my son, Yahya. He is the operating surgeon. And push the needle just beneath, look at this, just beneath the endometrium. And you see the swelling. So by this we can guarantee that the precious platelet-rich plasma will stay here, okay? So when I did my first case, I came happy to India declaring that my success rate is 100%. So I did only one case and she got pregnant. So that's why I call it 100%. We are evaluating the technique now. So I'll finish my presentation by the fibroid. Dr. Shankari, do you believe that the meta-analysis and the systematic review